the Deuk Spine Institute here in Melbourne, Florida, and we are getting ready to do our final surgery of the day. We saved the best for last. Our patient has two herniated discs, one at L4-5, one at L5-S1. He has back pain and left leg pain. So we're going to be treating the back and left leg pain today. I expect her back and left leg pain to be gone after the surgery. We're doing an endoscopic surgery called the Deuk laser disc repair. We're not doing open surgery or microsurgery. We're doing endoscopic surgery. All right. Dr. Deuk here, are you okay? Can you feel me touching you? All right, I'm going to give you some numbing medicine, okay? All right, just relax. Do a little bit of numbing medicine. It's going to feel a little burn. That's normal. You're okay, I promise. Everything's good. We need you awake in the beginning to help me. I know. It's just numbing medicine going in. 4 cc's. And this should not be here. It's a very delicate part of the scope. You okay? All right. I'm going to put you to sleep in a little bit, all right? But I need you awake for the beginning. If you have pain, just say ouch. All right, I'll give you some more numbing medicine. Hold this. Good. Now, we have to have you awake for the beginning because I need your help. And then we'll put you to sleep once we get where we need to go, okay? Deal? All right. Hold on. Shot? Alrighty then. Let's start at 5-1. Any way we can clean that up, and I need the lights down just a little bit. Blood pressure is okay? Let's see if we can. Sometimes I wonder about our numbing medicines. All right, let's see. I think we're off orbitally. I think your WAG is okay. I think your orbit's off. Yeah, I know. Shot? So that's definitely better. It's just hard to believe that's the best. Let's keep going on the orbit and see if we can't make it better. Shot. One more. Shot. I'm hoping that foramen opens up, but maybe it won't. I think that may be the best we can do there. What do you think?
Yeah, I think that's about
Probably back a little bit. Numbing medicine. Just giving you more numbing medicine, that's all. Hopefully it'll make it more comfortable for you, okay? Sorry about that. Shot? All right. Shot? 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 Where do you feel that? Is that in your back? Shot? Feeling the facet joint? Yes. Shot? We want to go around it. You're doing great, by the way. Shot? This is the worst part of the surgery, and I apologize. Shot? Shot? But I do need your help. You understand? Once you get through this, it's going to be sleepy time. Shot? All right. Huh? Shot? We need to go AP. Let's see where we are. We're going to use a combination of front, back, and side-to-side pictures. The L5-S1 is always the hardest disc to get to. So I'm pretty close. Let's go back to a lateral. I just need to be a little more lateral than I am. L5-S1, which is where we're aiming for, is the hardest disc to get to. You can see she's got a little bit of spina bifida occulta there. You want to show them on that? We'll probably see it again. Basically, the spine never fused properly. Shot. During embryological development. Shot. Happens. It's quite common, actually. Shot. I need to be a little bit lower. You're doing great. Shot. 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 Where do you feel that? Shot. When I say shot, what I mean is I'm take a picture basically. Shot. AP. All right, we're going to look at an AP view again. I'm really close to where I need to be. You're doing great, by the way. She's a trooper, honestly. She's doing phenomenal. That's really good. All right, so show them the spina bifida occulta for S1. Yep, that's it right there. Jordan, you've got the eye. I love it. All right, so it didn't fuse there. And it didn't form a nice little bridge because you could see they never came together. I'm just showing you that not because that's a problem for her, but that's just something we happen to see and we want to point it out to you so you could identify it and understand it. All right, we're very close to where we need to be for her. You okay? All right. Where do you feel that? Where in your leg? To your toe? Still feel it? Huh? Shot? Let's go AP again. Pedicle 5 is perfect. Maybe we're off a little bit on WAG. Let's take a look. The AP shows I'm just lateral to the facet joint. There is a little retrolisthesis. You can see it on the MRI. We're definitely at the right spot. It's a full disc there. Are you okay? Shot. All right, let's see if we can bring the L5 pedicle. The end plates look good, but the L5 pedicle looks off just a little bit. Let's see if we can't fix both. Other way? No, not on the orbit. This is a WAG issue. I'm not moving my needle yet because I want to get the x-ray picture better. See, that is pretty darn good with the pedicle, but the orbit is off. You can see the two rabbit ears of the facet, L5 superior facet. So So let's get the orbit. That's better. I mean, do I need to be a little lower? That may be the situation. I hate to have to relocate this, but I probably do. Shot. Want to come in a little bit lower than I was before. Shot. I'm sorry, I know it's a bit uncomfortable. Shot. I feel the herniation. Shot. Shot. You're doing great. So what I did, folks, is I adjusted my trajectory just a millimeter and went lower towards the tailbone a millimeter. And what that did is it went just underneath the nerve root. So we're inside 5-1 nicely. Let's get an AP to verify that. Gonna make an incision. The incision for the surgery is 7 millimeters. What is it with this stuff? Luis. This is all McKesson? Numbing medicine? Where are they getting it from? Sorry about that. I'm so sorry. Can't trust any of these pharmaceutical companies anymore. So aggravating. Shot? Yeah, we're good. All right, we made our incision, yes. And we're going to access the next disc, which is, I think I made that big enough. I may have to make it a little bit bigger. But the next disc we're going to is the, I think we're okay for now. Shot? Is the next one up. L4-5. Shot? She good? All right. Shot? Almost done, promise. You're doing really good. Everything's going well. I've got to just get into this other disc and we'll be done. We'll be able to put you to sleep, that is, I should say. We'll be done with you being awake. You okay? I know, almost there. I apologize. We're right at your other bad disc. Shot. See how much faster the 4-5 goes than the 5-1, because the 5-1 is far more difficult. AP. So X-rays don't really show herniated disc that well. That's perfect. Let's go back to a lateral. But you see how quickly 4-5 is to get to. We're already there, and 5-1 took us 10 times longer, because 5-1 is the hardest disc to get into transforaminally. All right. Very good. You comfy? Shot. All right. Shot. We're going to put you to sleep in just a minute, okay? Now, how long have you had back pain for? A year? Did it happen with an accident or something? You fell off something? A ladder? What's worse, your back pain or your leg pain? All right. So she has back pain and leg pain. We're going to fix both today. But she's got small tears in her disc with herniations. The L5-S1 is a bigger herniation. The L4-5 is smaller. So we're doing L4-5, L5-S1. Everybody in agreement? L4-5, L5-S1, left side. We're on the left side. Are you comfy? All right. How bad is that on a scale of 1 to 10?
All of the numbers.
Give me a number, 1 to 10. 10 is the worst pain. Huh? That was the source? All right, that was your bottom disc. That was the L5-S1. You got a huge tear. We're going to fix that for you. That was a 10 over 10 at L5-S1. And that's concordant. You okay? We're going to put you to sleep soon, I promise you. I apologize. I apologize. Is that better? Huh? All right. I'll give you a minute. I'm sorry about that. So the surgery we're doing is to repair 2 herniated discs. To repair them, also there will be no scar tissue except for the scar on her skin, because we're not going to be damaging anything inside of her except for her skin. Inside we're going to pass wire and a dilator, which is going to gently spread the tissues open rather than cutting them like traditional spine surgery. So there'll be no scar tissue with the surgery, there will be no bleeding, and they will be entering the disc that's damaged right through the damaged part. Are you better? Yeah. All right. No pain? Huh? A lot of pain. Right now? Do you feel pain now? Yes. Okay, all right. So she is having pain there. All right, we're ready to go to sleep. Go ahead and count from 1 to 100 out loud. You can see a little tear. So this, can you count from 1 to 100 out loud, please? Yeah. So clearly L5-S1, positive. How much pain did you feel right now? Give me a number. So 3, not much pain at all. We are going to treat it though, because she did say she had pain there, and I don't want to leave it untreated. You could see the small bulge on the MRI. It looks like that tear has mostly healed itself, but you could still see a little bit of the tear there going backwards towards the bulge. So most of the pain, I would say, is coming from L5-S1, and a small amount of the pain is coming from L4-5. We're going to treat both because I don't want her leaving here with pain. Shot? All right, next step is to remove the needle. Shot? I've got my guide wire here. I'm going to remove the needle out of the foramen at L5-S1 on the left side. Our patient is asleep. The blue stuff is the dye we use. I think we got a pretty good sized incision. I'm going to bring the dilator down. Now, remember earlier I said the only scar there's going to be is on her skin. There's a 7 millimeter 1/4 inch incision right there. And I'm going to be bringing this dilator down to the disc, past the skin, past the muscle and the fascia. And what it does is it spreads the tissues so that, shot? So that we can get to the disc and the tear where the pain is. You see that tear down there? We want to get down there. Yeah, I think the incision is, I need to make it a little bit bigger. Because it's not letting the dilator go down. So this stage of the surgery, we're going down to the disc. I'm literally using this dilator to dilate or spread open the muscle. Rather than damaging the muscle, we're spreading it. We're coming down to that L5-S1 disc there, right where the tear is. This is going to be the most painful part of the surgery for the patient, is getting into that tear. And she's going to not like it. All right, Doc, I'm right at the tear. Let me know how she's doing. Is she comfortable enough? I can proceed? All right. She's just moving a little bit. Maybe reflexive shot. Yeah. She's not happy about it. You want me to wait? I'll just wait a minute because she's... All right, so we want to get her deep enough where she's comfortable while we go through this painful part of the disc. This step of the surgery, going through the tear that's causing all of her pain, is obviously going to be the most uncomfortable part of the surgery because we're going through the actual source of the pain where all the inflammation is. If you had a pimple on your skin, it would be like putting your finger on the pimple and pushing on it directly on the inflammation. So that's going to be the most painful part of that spot on your skin. Let me know when you have her comfortable. Huh?
Dr. Deuk,
Yeah,
do you have time for a question?
I do. I have a time for a question, but let's first run our video animation so everyone can see why herniated discs and annular tears actually cause back pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deuk.
I know we have a question, so while we're placing our tube, let's go ahead and show our audience the video of what the Deuk laser disc repair actually does inside the disc.
All right, doctor.
Cause of chronic back pain.
Works.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and
Okay, folks, we just came down with the scope into the tube, which you can all see, and I am inside the disc at this point, and the blue stuff is the herniated disc material. The degenerated disc material, it stains blue with the dye. This is her more painful disc of the two. We don't know before surgery which discs are going to be more painful. There's no way to tell based on the MRI. There's no way to tell based on any test in the world except for the discogram. And the discogram, we just did it, and you could see from her response, this disc was a 10 out of 10. She had a lot of pain coming from this particular disc. And if you look at the actual discogram picture on the x-ray, it shows a huge tear in this disc, a big tear, like literally top to bottom in the annulus fibrosus, the wall of the disc. And that tear has basically become severely inflamed, and that inflammation is what's causing all the pain. All right, so now we're going to use our laser fiber to remove the herniated nucleus pulposus. It's called the interposed nuclear material. It's stuck inside the annular tear, stuck to the wall of the tear. We're going to use this laser to remove it. And then we're going to finish this disc and we're going to move on to the next one. The next one gave very little pain, so I'm not going to spend a lot of time there, but there is a small tear. And the reason why the other disc is not as painful is I think she's healed it partially. It just hasn't been completely healed. So by healing partially, most of the pain from the inflammation in the tear is gone. But she still has some pain there, she told us. She just didn't have quite as much pain as this disc. So we're starting at L5-S1, and then we're going to move to the L4-5. But I'm excited for her. I think she's going to do really well. By the way, the 3-level cervical Deuk laser disc repair we did earlier is already gone, and he's already got strength back in his hand. It's not normal, but it's better. Dramatically better, and he's got feeling back in his arm, his forearm and his hand on the right side. So he woke up in the recovery and he said, I can actually feel my forearm and my hand on the right side, and my hand is moving a lot better, because he couldn't even move his hand before surgery. Literally could not move that right hand, and now his hand is moving. It's definitely not normal, but it's going to take a long time for it to get back to the maximum function. I think he'll get 90% back if I had to pick a number. All right, now there's a piece of herniation. I'm going to go grab it and take it out. By the way, we got Thanksgiving coming up in 2 days. We have a lot to be thankful for here at Deuk Spine Institute. Most notably, we have the fact that people get their lives back, getting rid of their pain. Okay, you cannot do that, my friend. You have very few things you have to do, and keeping that wire from hitting me is one of them. Okay? All right. this stuff away and clean up the tear. We're getting rid of her pain. Surgeon. So we're the most skilled of all surgeons. Nerve compression or spinal cord compression.